Right. I'd like to welcome everyone to Grand Rounds. Good morning. We'll go through a few announcements as usual. Hope everyone can hear me okay.
Good morning, guys. Sorry, it's just me. Dr. Wason is helping me put my PowerPoint up there. Can you guys see that?
Yes.
Yes, okay. Perfect. Okay, so my project is pregnancy outcomes after prenatal diagnosis of a congenital heart defect. And I want to thank Dr. Montero for helping me thus far with the project. So congenital cardiac anomalies comprise the most common group of fetal structural anomalies, with the incidence ranging from 8 to 12 per 1,000 live births. About 7% of all neonatal deaths are attributed to congenital malformations, but about 25% of these deaths are secondary to severe congenital cardiac anomalies. The increasing prevalence of diabetes and obesity has really contributed to the rise in these cardiac anomalies. You can attribute a 4.2% risk from pregestational diabetes and an 8% risk from pre-pregnancy obesity. Several papers have already defined congenital cardiac anomalies, and they structure them in two categories as left to right shunts or right to left shunts. They also categorize them as no impact on fetal well-being all the way to severe impact or death. Congenital cardiac anomalies have been more easily diagnosed with prenatal ultrasounds and echoes over the last few years. And has increased over recent years, with cardiovascular anomalies being 6.5 times higher than actually chromosomal anomalies. Prenatal diagnoses of anomalies have given parents time to weigh the pros and cons of continuing pregnancy versus early termination. For those who opted to continue their pregnancy, the early diagnosis actually allows them to have continuous observation of the disease progress and appropriate referral to subspecialists. Augusta University's maternal fetal medicine office actually has created a birth defects registry that started back in 2012, and last inputted was in 2019, which was originally created for the purposes of provider education and quality improvement. But with this table, the MRNs have actually been turned into an electronic fetal record with the parents, the mother's charts, as well as the baby's charts. And the data that it includes is just their G's and P's, prior obstetrical, social, and medical history, if they got any non-invasive prenatal screening, if they had any invasive prenatal screening, which gestation the abnormality was discovered, any recommendations that MFM gave them if they decided to take that or do something differently. If they decided to terminate, that was listed in what gestational age, any interventions that they had in pregnancy to help with the anomaly that was found, and then the outcome of delivery and whether it went as planned, whether it was just a vaginal delivery or a C-section, or if they had to use like an operative vaginal delivery, all of that was listed. And then it also, you can connect the baby's charts with the mom's chart and look at their outcomes. So the registry already has like the morbidity and mortality to include like APGARs, the presence of the abnormalities at birth, if the patient decided to do palliative care, and how long they lived after that decision was made, if they were admitted to NICU and died while the baby was there, or if they were able to make it to discharge, any interventions that was done in the NICU, and then outcomes at 6 and 12 months of age. So this is a large database with several like different categories that I didn't even list here as well. So the birth defects registry is actually can be organized by systems-based anomalies. So you would just have to search through the anomalies to find the cardiac deficits. One of the initial projects of when this database was created was to find which factors may have influenced mothers to undergo termination with these fetal anomalies. And like I said, the database was literally just the black book with the MRNs that the 3rd and 4th year medical students that have since graduated turned into like an electronic database. So for my study design, I'm just doing a retrospective chart review of mothers and their babies after a fetal diagnosis of cardiac anomalies. My primary objective is to report short-term outcomes of infants after their diagnosis. The idea is to compare each individual cardiac anomaly with the outcome, and then was it a termination of pregnancy, an intrauterine fetal demise, a live birth, and then short-term survival, basically a yes or no question. And then looking at the interventions, whether it was medical or surgical management or if the baby got palliative care. The secondary outcome was to actually evaluate the pediatric outcomes at ages 6 and 12 months. And the chart is well documented, or the database has these already well documented. As far as statistical analysis, I was going to look at the differences in outcome between infants with similar diagnoses. So that would be compared with a student's t-test for the continuous variables such as gestational age, weight, days in the NICU, and APGARs, and then use a Pearson's chi-square statistic for those with categorical variables such as like the live birth, termination of pregnancy, and IUFD. So the study design currently is loosely defined, but it's pretty easy to define just surface level or broad spectrum. So inclusion, all the cardiac fetal anomalies that are in this database between 2012 and 2019. I'm going to exclude out those that weren't delivered in the hospital, our hospital, because I wouldn't have the information for that. And then if they did not follow up with MFM or if they were just a referral, basically. There are studies that have set precedents for this, and this one specifically looks at all of the cardiac anomalies on the left side, and then it has basically pregnancy terminated, born alive, if they had surgery, and the age at the last hospital visit. There's also precedents been set for, through this paper, which is outcomes of infants with prenatally diagnosed congenital heart disease delivered in a tertiary care pediatric cardiac facility. And it does something very similar, just defining basically live births, the gestational age, did they receive comfort care, if they survived, and then did they come back for follow-up. So the current status of this project is the database was completed this month. It now includes 540 mothers seen by our MFM providers. I did sort through that and found like 100 fetal cardiac anomalies with all the major and minor congenital anomalies. So the next steps in the project, because the IRB for the original project was actually started about 3 years ago, there's a yearly update that is due in March, which I will start working on. I'm now ready to do statistical analysis of my data collection. Because there's so much information in here, it has the ability to have additional papers. And then Dr. Montero and I talked about expanding the data collection at least through the anomalies from 2020. The original IRB has the ability to go up to 1,000 moms and 1,000 babies, so we have plenty more room to go. And then addition of medical students to continue to help me if I have to add more patients to the database. And here are some of the references that I've already started looking at, but there's a good amount of papers that kind of already clearly define the process in which I need to take. And that's it.
Thank you, Dr. Jones. So we'll open it up for questions. Let's see, Dr. DeVoe.
This is actually, it's a very interesting area. And I think there are some things that you really need to consider here, because probably not likely that there are going to be any epiphanies or things that are greatly different from what's already been reported. But, you know, our population isn't quite the same as the ones in your research papers, so something might come out. I think one of the things you need to be sure to look for are babies for whom the cardiac anomaly is only part of the syndrome, and there's other things that are going to be confounders in the neonatal outcomes. That's very important, because there are numerous syndromes which have cardiac anomalies and many other things that weigh on the baby's outcome. Likewise, if there are karyotype or microarray findings, that would be useful as well, because there is a abundance of babies that do have like the George syndrome and Down syndrome, trisomy 18, trisomy 13, in which cardiac anomalies are a frequent feature. So that would be something important as well. I think the third thing is really the timing of diagnosis, because one of the things that you're always stuck with is that making diagnosis of cardiac anomalies may be subtle, may not be done early. And I think so time of diagnosis would be an important variable to look at in terms of the decision making for the patient and then for the fetus.
Thank you, Dr. DeVoe. The database actually does have the timing of diagnosis, so this is something definitely easy to put for statistical analysis.
I guess the last thing I would have you at least think about is there are a lot of factors that go into patient decision making. You may not have the ability to drill down as to exactly why a patient decided to continue or not continue pregnancy. So if that is available in the database, that would be very important.
I believe Dr. Lehman has his hand up.
Yes, hi. Yeah, I think this is a good idea to do this. Can you just clarify what your primary outcome is and how you selected it and how you're going to determine it? I missed that.
Sure. So the primary outcome is just to look at the short-term outcomes of infants. So basically, did mom terminate, or was there intrauterine fetal demise because of the anomaly? Was there a live birth? And then basically it's just a short-term survival. So the answers are like yes or no, basically.
So you don't really have a control group. This is more a descriptive longitudinal study then?
Yes, sir.
Other questions? I see somebody's hand up, but I don't know who it is.
This is Chad, right? I think it's important for us to use the database that we have. I think it's underutilized, and so I certainly appreciate the fact that the database is going to be used once again for looking at our patient population, because while there are lots of similar areas to Augusta in the country, I think it's important for us to know our own patient population, and this population where we are sort of the oasis in the middle of a medical desert is not unique, but it's not as frequent, but it's becoming more frequent. So I applaud you for using the database for sure. I always am interested in knowing whether our patients, and you can look at this database, I think, for location of where the patient's primary residence was, because as we continue to have a shortage of workforce, and much of what happens when you have a congenital anomaly is a factor of health, overall health for the patient, especially access to care. Maybe we can also at some point, or you can include it in this, whether the patient was a certain distance from the hospital as a secondary factor, because we know that there's poorer outcomes, especially for things like preterm birth, which impacts survivability for patients that are farther from the hospital.
Thank you, Dr. Ray.
I would also add that I would look at the time to referral to MFM, because I suspect sometimes this might be suspected outside and there's a delay in referral.
Okay.
To the MFM. I see another hand up, but I don't know. I can't tell who it is.
It's me.
Okay.
I think one more thing to think about, and where this could become extremely useful, is forming a basis for counseling patients based on our own experience. Because, if you've seen one high-risk medical center, you've seen one high-risk medical center, I think this would be information that would be very valuable to helping with counseling, and also to maybe have the idea that these are patients, especially those that have complex congenital heart disease, that are best handled with basically a team conference, so that we unite the neonatal team and the pediatric cardiac surgery team in terms of using the information that we have, and then going forward with management planning for the patient if that's not already being done.
Thank you, sir.
Any other comments or questions? I would just encourage the interns who are listening. This is a great resource to consider another research project using this database, coming up with a question that you would like to have answered. So I encourage you to look into this. Not seeing any other hands up. So Dr. Jones, thank you for that presentation. And I believe that will conclude our session this morning.
Thank you, Dr. Higgins.
Thank you. Have a good day.